Good morning, everyone. I have to begin with a little bit of an apology. As best I can remember, this is only the second lecture I have given in similar circumstances for which I have not chosen an appropriate scientific or clinical topic. But neurologists, neurology, and the American Academy of Neurology are facing an unparalleled number of challenges today that impact our field, impact it adversely to one degree or another, and that we must address if we are to continue to remain indispensable to our members and achieve our mission of promoting the highest quality patient-centered neurologic care while enhancing member career satisfaction. We also seek to attract the best medical students into neurology and assure them of a professionally satisfying, indeed, hopefully exciting career, whether in an academic setting, a large multi-specialty clinic, or solo or small group practice. To an extent, many of our challenges are those of medicine in general. But at the same time, many of those facing the non-procedural specialties seem more severe and intractable than those of our colleagues for whom procedural interventions account for a large part of their practices. There are no easy answers or solutions, and additionally, there is almost a schizophrenic aspect to the situation in which we find ourselves today. To paraphrase Dickens, neurologists find themselves experiencing both the best of times and the worst of times. In terms of best, neurology has never been more exciting because of the accelerating pace of advances in both basic and clinical neuroscience, and even more importantly, the rate at which laboratory discoveries are being translated into new therapeutic interventions that offer unparalleled hope for controlling or even curing neurological diseases by targeting specific genes, molecules, and circuits. As one example, consider the emergence of targeted monoclonal antibodies as treatment options now available for patients with multiple sclerosis. Other examples might include endovascular thrombectomy for selected patients with acute ischemic stroke, and new interventions for brain tumors previously considered largely untreatable. We also have specialized units, such as neurological ICUs and epilepsy monitoring units, that have made huge differences in the outcome of critically ill and therapeutically complex patients. At the same time, all of us are legitimately frustrated by the many aspects of neurological practice that do not easily fit into a systems framework that works best, indeed sometimes even appears to be designed for, procedural specialties. That is, a clearly identifiable problem, a specific intervention that usually has relatively clear beginning and end times and desired outcomes, that are typically evident either immediately or within a relatively short time frame. Because of this background and the limited time I'm allotted, what I have chosen to do this morning is offer a few selected examples of some of the challenges facing neurology today. At the same time, I will recognize opportunities available to address them. Time does not permit an exhaustive list, but it is one, I think, that highlights at least some of the challenges we face. And I will begin with the crisis in healthcare and the urgent need for payment reform. Payment reform is essential. We are all frustrated by the current system, which is inequitable, often inconsistent, and frequently incomprehensible. Our system of reimbursement has resulted in a healthcare system whose cost and outcomes, when compared to other industrialized nations, is simply embarrassing. One Kaiser Health economist has recently characterized unnecessary health costs as, and I quote, sucking the life out of the American economy. This is hardly an overstatement, given that the US now spends just a hair under $3 trillion each year on health care, by far the highest of any country in the world. Even more alarmingly, this figure is approaching 20% of the United States gross national product. Last year, the US economy grew at a rate of 2.2%, but healthcare costs again grew faster, although at 3.6%, the rate was the lowest in 50 years. In the most recent health system scorecard issued by the Commonwealth Fund comparing health systems in 11 industrialized countries, the US ranks last, as it has in previous surveys, in terms of various standard measures, including access, patient safety, efficiency, fairness, and outcomes. And this slide illustrates the rankings broken down by the individual measures that were assessed. The bottom line of figures shows the per capita cost of healthcare, and not surprisingly, it is highest in the United States. But other surveys have also demonstrated that the US is also now lagging badly in adopting information technology, as well as national policies that promote quality improvement. In comparison with other industrialized countries, we manage chronic conditions less well, and delivery of care in the US is much less well coordinated. We also underutilize non-physician clinicians such as nurse practitioners, physician's assistants, and other physician extenders. We score particularly poorly on implementing strategies that promote health and on providing care that is accessible, reliably safe, coordinated, efficient, and fair. It has become clear to many physicians and healthcare leaders that simply tinkering further with the current system will not move us sufficiently from the status quo to a system that is consistently less costly, more efficient, and offers higher quality. To this point, the most notable difference between the United States and other countries we're compared with is our lack of universal health insurance coverage. It is, I believe, no longer possible to pretend that we can make meaningful system-wide changes that promote access to care, implement preventive strategies, and assure equity in both prevention and treatment strategies for the entire population of the country without universal health insurance coverage. Essential aspects of any serious effort to reform payment are to reduce cost and improve quality, some things that the US healthcare sector has been notoriously poor at. And without a significant change in our current system, this is just not possible as long as we emphasize billable services without critical analysis of the quality of our interventions in relation to their cost. As a result, we are seeing an increasing emphasis by CMS and other major payers on value-based payments, a trend that was entirely predicted and one that will continue to grow most likely at an accelerated pace. In fact, new entrepreneurs and investors are increasingly visible in the healthcare markets, introducing business models that make money not by capitalizing on illness, but rather by keeping people healthier and reducing waste. New and powerful analytic tools are aiding this transformation, and commercializing the creation of value is the basis of new business models and strategies. I'm sure that there will continue to be a select group of patients who are willing and able to pay for a concierge-like first-class service. This, of course, has been the airline's business model for years. The vast majority of travelers fly coach, searching the internet for best bargains. However, a reliable minority continues to prefer flying first class no matter what it costs. One can already visualize a similar transition within our healthcare system that is occurring as part of payment reform and seems to be moving at a much faster pace than anyone thought possible just a few years ago. There are a number of opportunities for the Academy to assist its members in adjusting to the new requirements that are changing many of the previous rules and methods that have provided historic frameworks for most billing practices. Now, of course, it's a new world as payment reform is implemented. The Academy has already developed a number of resources that are available to address various major topics, such as those listed in this slide. Aspects of each of these topics are covered using a number of different materials, including webinars, review courses at the annual and regional meetings, videos and articles in various Academy publications, especially AAN News. But we must do more, including the following. First, we must assist all neurologists, but especially those in small practice settings and not part of an ACO, large medical center, or multi-specialty clinic, whose resources will be most strained by the necessary and unavoidable changes required by payment reform. As the shift in payment evolves from specific volumes of services to value-based reimbursement for episodes of care, we must focus to an even greater extent than we do now on assisting our members in developing meaningful quality measures and in collecting data that demonstrate the validity and value of those measures. Development of a registry is a critical part of this effort that should benefit all our members, and I will comment more on this momentarily. A number of relevant updates have appeared in AAN News, Neurology Today, various blogs and newsletters and elsewhere, and I hope that you're beginning to keep up with the rapid pace of events. It is vital for us to continue to demonstrate the value of neurologists aggressively in as wide a group of settings as possible. The Value of Neurology Work Group, chaired by Joel Kaufman, recently completed an informative retrospective analysis of the costs and benefits of neurologist ambulatory care. This showed that care of patients with selected chronic neurological diseases is associated with cost savings and improved outcomes when those patients are managed by neurologists compared to primary care physicians. A study of VA inpatients with stroke demonstrated that while care by neurologists was somewhat more expensive, patients had significantly improved morbidity and mortality. The Academy needs to continue taking the lead in encouraging other studies of the role and benefit of neurologists. I believe that the positive impact we make to patients will most likely be through earlier and accurate diagnosis, choosing the most appropriate therapeutic interventions that have the greatest chance of reducing disability and also improving quality of life. But I also believe it would be worthwhile to design studies that can validate our assumption that increased use of advanced practice providers, particularly for routine office appointments and facilitating visits to patients in their homes or chronic care facilities, is also cost-effective. Implementing a clinical data registry, we have named ours, that is in development now, the Axon Registry, has been a relatively recent priority for us. This type of registry is a structured way of collecting data on a set of patients in order to answer questions about treatments or procedures, practice patterns, and patient outcomes. CMS and other policymakers have clearly indicated their support for such registries, as they view them as repositories of systematically collected clinical data that are essential for creating a high-value healthcare system that will reduce costs and improve quality. Several specialty societies, including the American Academy of Ophthalmology, the American College of Cardiology, and the American Academy of Family Practice, have already implemented or are well into developing clinical registries. Although there are multiple uses for a clinical registry once it is fully implemented, its primary purpose, as I said, is to serve as a repository for clinical data. These data can then be used to identify gaps in care, areas for improving quality and outcomes, and decreasing costs. Importantly, such data should also be extremely helpful in demonstrating the value that neurologists add to patient management. And finally, these data should assist in meeting regulatory reporting requirements. I want to formally acknowledge the remarkable talent and knowledge that our members bring to the committees and subcommittees charged with payment and regulatory issues, quality and outcome measures, coding, and all manner of complex economics issues relevant to the practice of medicine today. I didn't have the space to list all the members of these committees and subcommittees, but I have listed the chair and vice chair for many of them. We could not do what we do without their remarkable time commitment and arcane expertise. Let me turn now to the growth and success of neurology subspecialty societies. As neurology becomes ever more complex, it is increasingly difficult for neurologists to remain current about all the different neurological disorders, the newest treatments for these, and advances in relevant diagnostic testing. It is not surprising, then, that more and more neurologists are developing expertise in at least one subspecialty. This, of course, has been true for some time in academic medical centers, but it is now increasingly the case also in large multi-specialty group practices and large hospital-based clinics. I believe that available evidence, albeit quite limited, indicates that with scarce resources and little time, neurologists with strong subspecialty interests will increasingly join and actively participate in the most relevant subspecialty society, a natural evolution. But a potential concern for us is that the Academy could lose such members to other societies, but fortunately, at the present time, nearly all remain members of the Academy. I believe that there is a critical need for the AAN to expand and interact more effectively with our colleagues who belong to neurological subspecialty societies. And this has been one of my concerns and priorities in the last 4 years. The Academy will most likely continue to offer resources and programs that are considerably larger and more diverse than those of most subspecialty societies. It makes sense from both resource and professional perspectives for the AAN to expand and strengthen partnerships with neurological subspecialty societies in circumstances that have proved effective on a limited scale. Examples of current partnerships include political advocacy, development of guidelines, and position papers, and at least in one instance to date, management services. At the same time, such partnerships might not only be cost-effective, but also serve the important role of reminding all of us, whatever our subspecialty interest may be, that most of us are first and foremost neurologists. I am thus proposing that the Academy create a Council of Neurological Subspecialty Societies, or CNSS. This would have considerable analogy to two other organizations, the Council of Medical Specialty Societies and the Council of Specialty Societies. The Council of Medical Specialty Societies, or CMSS, is an independent organization comprised of all the medical and surgical specialties defined by the American Board of Medical Specialties as primary specialties. In contrast, the Council of Specialty Societies is one of several councils of the American College of Physicians. The AAN has representation on both. In cases where a strong national neurological subspecialty society already exists, the American Epilepsy Society, for example, that organization should be invited to become a member of the new Council of Neurological Subspecialty Societies. When there is no independent neurological subspecialty society, as for example in the case of both multiple sclerosis and sleep, we would work with the corresponding AAN section to assure adequate representation. An exploratory meeting between the Academy and neurological subspecialty societies and sections was held this past year in Las Vegas, and it proved to be encouraging for the formal development of a Council of Neurological Subspecialty Societies. Next, I want to talk a bit about a major challenge for us, and that is the growing shortage of neurologists. A major challenge not only for our field, but for the nation, I believe, is a future shortfall in the number of US neurologists. The Academy supported a study of this issue, which was published in our journal Neurology in 2013. The main findings included the following. First, the shortage of neurologists in 2012 was 11%, but this was projected to increase to just under 20% by 2025. The reasons for this include an increasing demand for neurologist services due to the aging US population and the age-related increase in neurological disorders, significantly higher utilization healthcare rates for neurological services by older patients, and a greater number of patients accessing the healthcare system as a result of the Patient Protection and Affordable Care Act, or Obamacare. A similar situation has been described for child neurologists as well. One important component of addressing the supply problem is increased integration of advanced practice providers, or APPs, into neurology practices and hospital services. Advanced practice provider is a useful umbrella term that encompasses nurse practitioners, physician's assistants, advanced practice registered nurses, and advanced practice nurses. As a personal example, the Department of Neurology at Columbia currently employs 15 nurse practitioners, 4 on an inpatient service that manages neurological patients with significant medical comorbidities, 2 on the stroke service, and 1 in the epilepsy monitoring unit. In addition, there are 8 working in our outpatient clinics, 3 in neuro-oncology, 1 in multiple sclerosis, 1 in adult epilepsy, and 2 in pediatric epilepsy. These advanced practice providers have added a valuable and important clinical dimension to both our inpatient and outpatient care teams, and they are consistently rated highly in both patient and family surveys. Our neurology house staff and attendings likewise view them enthusiastically as integral parts now of the care team. Getting advanced practice providers more involved in the academy has been another of my priorities during my term as president. Dr. Heidi Schwartz, the new chair of the practice committee, was asked jointly by both the practice and education committees to chair a joint work group with considering a proposal to create a membership category for neurology advanced care practitioners. The work group made a very strong recommendation to the practice committee, which was accepted unanimously, that the academy develop a targeted membership drive to recruit neurology advanced practice providers into the academy. In addition, the work group recommended that the education committee develop special education tracks and materials for neurology APPs, beginning with this meeting. These recommendations were subsequently approved by the board. I am confident that neurology advanced practice providers will be a growing and vital addition to the Academy's membership and assist in meeting the increased need for neurological services. Teleneurology is another opportunity to extend neurologist services, particularly to rural areas where the lack of adequate numbers of neurologists is greatest. Increasing the number of medical students who choose neurology careers is also a critical concern, but one that is actually quite complicated, and I will have to defer that necessary discussion to another time. The fourth challenge I've chosen is that of burnout. Burnout is a serious issue for neurologists across the country. Burnout affects neurologists' satisfaction with their careers and limits their ability to demonstrate the value of what they do. Beginning about 20 years ago, there have been a growing number of studies that have identified physician distress across a wide range of specialties. Burnout is not the same as depression, although, of course, burnout physicians may be depressed. Rather, it is a chronic syndrome characterized by low personal assessment, decreased work effectiveness, depersonalization, and emotional exhaustion. While physicians experience burnout, as I said, may be depressed, they are also typically anxious, disillusioned, and find that their personal lives are suffering. There is some evidence correlating burnout with physician reports of suboptimal care. Other manifestations of burnout include increased rates of substance abuse, decreased career satisfaction, higher rates of divorce, and professional disillusionment. Burnout is neither rare nor trivial. National surveys of physician burnout have shown that over 45% of physicians report at least one symptom of burnout. While the causes of physician burnout are not fully understood, choice of specialty, personality type, practice setting, and types of patients are among the factors that have been identified at least as contributing to burnout. Rates of burnout vary with specialty. The highest rates are seen among emergency medicine physicians, general internists, family medicine practitioners, and neurologists. General pediatricians, dermatologists, pathologists, and neurosurgeons have among the lowest rates. We have an important opportunity here. Dr. Terry Cassino, who succeeds me as president, has made enhancing neurologist career satisfaction one of his highest priorities. A neurologist burnout task force that is co-chaired by Drs. Cassino and Heidi Schwartz has been created and will be divided into two groups. One that will try to understand why neurologist burnout rates are significantly higher than those of physicians in other specialties, including surgery, pediatrics, and ophthalmology. But the other will consider potential mitigation strategies, clearly important aspect. This is a crucial issue, and I hope that the report of the task force will provide a framework for the Academy to study the issue further and make specific recommendations for mitigation. So please stay tuned. My last comments are going to relate to the issue of maintenance of certification. A significant number of members have expressed frustration and dissatisfaction with maintenance of certification, especially Part 4, which is that component designated improvement in medical practice. This has become a significant challenge to the AAN in recent years, especially this past one, in large part because persuasive arguments can be made both for and against maintenance of certification. Here, as in many things, the difficulty is less with the concept than it is with its implementation. It's important to remember that our Academy is legitimately viewed from two perspectives, and they are not identical. First, we are a member organization, and in that role, we must be responsive to our members' needs and concerns. It was in this context, acting on behalf of its membership, that the Academy formally asked the American Board of Psychiatry and Neurology, ABPN, to eliminate maintenance of certification Part 4, at least temporarily. Subsequently, the American Psychiatric Association, which of course shares our board, made the same request. But second, and also important, the AAN is a professional organization. And in this role, we have a major responsibility to the patients we serve. And it is from this latter perspective that we must therefore be concerned that our members who practice neurology are up to date in terms of relevant neuroscience, disease pathophysiology, diagnostic modalities, and therapeutic interventions. I was certified in 1975, and since that time, our field has been transformed spectacularly. Needless to say, little of what I knew at the time I was certified, almost none, is still valid today. It is impossible to imagine that I or any other neurologist who was to practice today as we did 40 years ago would be allowed to remain in practice. We would be guilty of malpractice. And it is from this second perspective that the concept of time-limited certification evolved. At the same time, however, there has been a parallel growth in patient and consumer advocacy organizations concerned with physicians' competence and quality. In this environment, I would ask if it's possible to present ourselves as up-to-date practitioners in the absence of some ongoing process that assures in measurable ways that we have continued to learn, apply new knowledge appropriately, and acquire the technical skills to utilize new diagnostic and therapeutic modalities. Without MOC, can we credibly argue that we are committed to ongoing education, continuous quality improvement, and use of new innovative diagnostic techniques and therapies? In today's environment, we must be able to assure our patients and the public that members of our profession self-regulate in meaningful and credible ways. It is unfortunate, I think, that the emphasis has been on certification, a process. The critical issue is undeniably maintenance of competence, a condition of possessing the required knowledge and specific qualifications necessary to be viewed by our peers as up-to-date and capable. Is there something that can be substituted for maintenance of certification that will equally be assuring to our patients and the public that all certified neurologists are engaged in meaningful and rigorous self-assessment, lifelong learning, and periodic re-credentialing? Perhaps, at least for some parts, and that's worth investigating. At the same time, I suspect that the positions of the American Board of Medical Specialties, as much as many of our members dislike it, in favor of MOC, would receive strong support from the great majority, if not all, patient advocacy groups, medical regulators, and major payers. And is it really credible that scrapping all aspects of MOC except licensure and CME, as some have advocated, would really meet the expectations of hospitals, patient advocacy group, payers, and most importantly, our patients and their families? This is, for better or worse, an issue that we do not own. It is true that at the present time there is a limited research base that supports MOC. But that is a statement that is equally true for much of what we do in medicine, including GME and CME. Even the efforts of such august bodies as the LCME and the ACGME, the respective accrediting bodies for medical schools and residency programs, have not been studied rigorously as to their effectiveness, which in any event would be almost impossible. But this should not be entirely surprising given what we do. In our day-to-day practices, much of what we conclude and recommend to our patients lacks support by unequivocal proof of effectiveness or superiority over other treatments. And this is unlikely to change soon, as much as we need to try. Nonetheless, we have become comfortable with that element of uncertainty and lack of proof, while always striving to do better. This should be an impetus for us to improve the research infrastructure that will allow us to identify what aspects of certification and MOC are effective and which are not. I can assure you that the AAN has made the feelings that many, probably a majority, of our members have about MOC unequivocally clear to the ABPN directors and also to the ABMS. And we intend to take the ABPN up on its offer, made to us in a letter last month, asking us to help the ABPN, and I quote, in its search for other types of acceptable MOC activities and ways in which MOC can be made more relevant and meaningful for its diplomats, end of quotation. We will do this because the issue is beyond doubt an important one. We must be able to demonstrate to our patients, their families, and society at large in believable ways that as neurologists we remain current in the changing knowledge and skills our practices demand as the time since our initial formal training grows ever more distant. As I end, let me emphasize how deeply grateful I am to the large number of people who have provided me with suggestions, information and discussion points. These included members of the board, committee chairs, executive staff, and many others. I thank them all for their interest and willingness to help with the content of my remarks. None of us, certainly not I, succeed in isolation, totally on our own. I have been fortunate to have been taught and guided at critical stages of my career by a group of remarkable individuals, themselves major leaders in neurology, including two indicated by asterisks on this slide, who were presidents of the Academy. Whatever success I have had, I owe in large part to their influence and example. I cannot conclude without acknowledging the Academy's outstanding staff and its exceptional executive director, Kathy Rydell, all of whom have long helped me look better than I actually am. And to all of you for the opportunity to have served as your president, to my colleagues on the Academy board and our many dedicated committee members who have made the past 2 years such an extraordinary experience. But most of all, to my family, shown here, my son Nathaniel, who's a medical student at Columbia, my wife Barbara, herself a neurologist, and my daughter Lauren, who's an attorney in San Francisco. They always make everything worthwhile. Thank you very much.